So thank you all for being here. My name is Dr. Stephanie Sullivan, and I'm the director of the Dr. Sidney Williams Center for Chiropractic Research here at Life University. I'm a DC graduate of Life University in 2008, and then I recently, it's gone by so fast, 2018 graduated from the University of Georgia with my PhD in neuroscience. So I'm really happy to be here and really excited to share this information with you. So over the course of the presentation, we'll be covering several different topics. Of course, this Research Foundation series is talking about case-based research. And we're going to specifically, I'll kick it off with a review of the value and historical perspective of case-based research. Then that'll be followed by Dr. Sean Neff, who will present an editor's perspective on case-based research. Dr. Brent Russell will bring in the ethical perspective. So what are things you need to be aware of from an ethics standpoint when you start doing case-based research? And then Dr. Deo is going to provide a step-by-step guide for how you can work through the process. So how do you actually kind of put rubber to the road and make it happen? So let's go ahead and get started. So this was actually a very challenging topic for me to research and present. And one of the main reasons, it's kind of interesting, is that there was so much that I wanted to share. So the hard part was really kind of pulling back and just sharing information that was available in 20 minutes. Because it honestly, it was really exciting, some of the stuff that I was coming across. So case-based research really provides the different pieces that allow for a bigger perspective and a bigger picture of what's actually going on in the patient presentation. And it really serves as a bridge between the clinical observation and what you all see as clinicians on a day-to-day basis, and then the research scientists. And it's been around for a very long time. So really the first scientific reports were case-based. I mean, even in ancient Egypt, they would actually pound the different information about different patients in stone. And then eventually, with technology for that time, we started recording information on papyrus. And one of the preserved scrolls is actually called the Edwin Smith Papyrus. It's dated around 1600 BC. And it's a collection of 48 different case reports on the head and neck, and then also the torso of individuals that the physician was seeing. And what was interesting is when you look through these, they're actually very similar to cases that are present today. For example, one of them was a jaw dislocation, and how the physician in Egypt actually set the jaw is the same way our physicians would do it today. Now, they did actually add in things like honey and alum when they were providing care to their patients. And it's kind of interesting that honey is now kind of has a resurgence and a renaissance in medicine because it's being used more and more in wound care because of its antimicrobial properties. So we have something to learn from these early case reports. And then there were also reports from, of course, Hippocrates had loads and loads of case reports, and they were actually very detailed. The Galenic case reports from Claudius Galen around 200 AD. And then there were a lot of Muslim scholars and physicians that were very good at capturing their records and reporting their information. And these reports were done from a very sophisticated perspective. So for example, in this one here by Al-Razi, he actually talks about a gentleman who fell from a horse and had an injury to his spine and the cervical spine. And then he talked about the symptoms presented in the hand and then how it was traced back then to the cervical spine. And essentially it's what is known today. So all that information are in the early case reports. So that was good for back then, but what about today? So is there still a place and a value for case reports? And absolutely, especially as we become more and more entrenched in evidence-based medicine or evidence-informed medicine. Because remember, evidence-informed practice is where you take into account, of course, the knowledge of the physician, but also the patient perspectives, and then the best available evidence. And that's where case reports can really provide some information. Because while RCTs are considered the gold standard, there's a lot that they're still missing, right? They can't capture the robust diversity of what actually occurs in a day-to-day practice. So because our patients are unique, they're not all the same when they come through the door. They require subtle nuances in their care. So case reports allow us that opportunity to share the information. So they're still very much valuable today. And this is beginning to be acknowledged by several different of your top tier journals. For example, the Biomed Central actually has a Journal of Medical Case Reports. The Lancet is another one that produces case reports. And for an example, within a 5-year time period, there were 103 studies case reports in the Lancet. Of those 103, 25 of them went on to become clinical studies. So case reports really provide the foundation, these foundational observations that can then be translated into clinical practice. And even other journals like the Journal of the American Academy of Dermatology are starting to provide small case report sections within their published journals. Now, there are several reasons to actually conduct a case report, and we'll go through each of these. So describing a new condition, studying mechanisms, talking about the development of new therapies, recognizing side effects, and then even education. So we'll start off with descriptions of new conditions. Now, this piece right here is actually it's considered one of the most important case reports in the history of medicine. Now, this was done by the CDC. They have a weekly report, and it talks about the case of an individual of 5 young individuals with pneumocystis pneumoniae. And essentially what that is, it's caused by, it's a yeast organism. It's very, very rare. So these were being seen in young individuals who wouldn't normally catch something like this. And then a few weeks later, there were several young men who there was another report in the CDC weekly report that talked about Kaposi sarcoma. So these were the first accounts of HIV and AIDS. So because of these reports, because the physicians took the time to document this information, then it collectively provided information on acquired immunodeficiency syndrome, or AIDS. And then there's other examples, like Parkinson's started talking about observations of a shaking palsy, and even Alzheimer's, studying the patient August Dieter, who showed up with mood changes, memory challenges, and then after he passed away, they did an examination of his brain, and that's where they actually started seeing the plaquing. So, and a more recent example is with COVID-19. There have been hundreds, if not thousands, of case reports about COVID-19. And it's one of the things that has allowed us to rapidly understand more about the condition and potential therapeutic opportunities, or how to even improve the care of the individuals. So, another thing that case reports are really good for is studying mechanisms. Because remember, we didn't always have MRIs and PET scans and things like that. So case reports really provided a way for us to learn and understand about physiology. So I'm going to cover a few of my favorites. My favorite category, if anyone has taken a university psychology class, they probably learned about Phineas Gage. So several people are nodding their head. So Phineas Gage, as you remember, had a 13.5-pound tamping iron that went through his skull and actually exited. He was able to function, like he was able to walk, he was able to talk, but what they started noticing is that he was having changes in his personality. So he became a little bit more obstinate. He had some lack of inhibition. Dr. Harlow described it as animal passions of a strong man. Let you interpret that one for yourself, but this provided several kind of interesting clues about the role of the prefrontal cortex. So from that, we were able to learn about executive function and also early neuroplasticity, because Phineas Gage actually improved in these conditions. So it starts to suggest, as you review these cases, that there's more detail. in the patient report. Some other cases, so Tan is another individual. Broca was the doctor, so you may recognize that from Broca's area. So Tan was presented to Dr. Broca with gangrene in the leg, and then he could understand language, but he couldn't speak it. So for him to communicate, the only word that he could say was tan. He would say tan, tan, and he was only able to produce some minimal hand gestures as a response as well. So through understanding tan and then his postmortem examination, so this is a picture of his brain, then they were understand one, that language was localized, at least for verbal communication, was localized to the left hemisphere, but then also where in the left hemisphere, so in the frontal area. So that later became known as Broca's area. And these don't happen in isolation, right? So several case reports came together in order to complete this understanding. So for example, there was another doctor who, an unfortunate individual who had a failed suicide attempt. And whenever he was using a gun, well, it actually exposed part of his skull. Well, the physician reports where he would actually place a spatula on the area of the brain similar to Broca's area, and the individual would no longer be able to speak. When he removed the spatula from the brain tissue, the individual was able to speak again. So again, it's a collection of case reports that provide information about how things work. And honestly, this one is my favorite. So this is HM, or Henry Gustav Mollison. So he actually had seizure disorder. So they went in and they did a bilateral medial temporal lobe resection. And from this case, so he ultimately lost his ability to record new memories. So from this and other cases, they were able to learn about the function of the hippocampus, but not only about the hippocampus, but also the fact that whenever HM would have some memory, whenever he would do some motor tasks, motor memory isn't stored. So memory is stored throughout the brain, right? So motor memory in particular is stored in a different region. So there was a lot of information that came out of studying this case relative to memory and how it functioned. So moving on, we'll talk about the development of therapies. So for example, this one is a really interesting and a recent one. So a doctor did a 10-person case report where he observed in seeing patients in the hospital, those who were on Pepcid actually had decreased symptoms of COVID-19 and improved mortality. So they were less likely to pass away from their COVID-19 symptoms. So from that, he published a report in, I think it was the Journal of Gut. And then now I was talking to a cardiologist the other day, and they actually recommended their patients take Pepcid if they get diagnosed with COVID-19. So case reports can have a big impact, especially when developing new therapies. And they also report on things like tuberculosis. So one of the things they noticed in TB patients who their medications seem to elevate mood. So from there, new antidepressants were developed. The same thing for schizophrenia patients who were on niacin, they noticed their cholesterol had improved. So niacin became something that was prescribed for cholesterol. Development of new therapies is also important for rare conditions, because to do a clinical trial when you only have maybe a handful of cases simply isn't realistic. So how do you care and how do you learn about these individuals? Well, case reports and case studies are one of the ways that you do that. So for rare conditions, development of new therapies is important. Another area is recognition of side effects. And there are several things that have kind of come about through different clinical studies. Sometimes things are pulled off the market, like fenfluramine or dexafluramine for weight loss. Case studies are what reported on pulmonary hypertension. The same for thalidomide. And some of you may remember the images of these children who had shorter limbs, who were born to mothers who were prescribed thalidomide for morning sickness. So that was something that once the case reports came out, they were able to take an action and remove thalidomide for individuals who are pregnant. Oral contraceptives reports actually showed that individuals could have thrombosis even in young women. So these are cautions that then been added. to, side effects. So whenever someone's taking oral contraceptives, they can just be mindful of that. And this is also very relevant to chiropractic. And it also gives us a good warning for case reports and case studies, because chiropractic does have side effects at times. So it can have some adverse events and we need to be mindful of it. But there's also another side of that. So just as with some of the negative press on stroke and chiropractic, when you actually go back and study it, then there are temporal differences or time-based differences. So individuals may have already been presenting to the office with a stroke in progress. So this is a caution to remember to take the case reports that you read always with a little bit of skepticism. See if there's bias as you read through the case reports or as you develop them on your own. So things to be mindful of. And then lastly, education. So education is another thing that case reports are really good for. So it's kind of, hey, here's what happened to me. Don't make the same mistake. So unforeseen circumstances that you can share. And public health warnings. And we've all opened a package, right? And we've had someone, like you read this warning, like don't eat gum from the urinal or the chainsaw thing. And you're like, well, why is this even in here? Because somewhere, someone actually did this. And an example, a recent example is with chloroquine. So chloroquine, when they were putting that out in the media that it was being examined as a treatment for COVID-19, there's something that chloroquine is also used in aquariums. And husband and wife ended up, okay, well, chloroquine helps. So they started ingesting aquarium-based chloroquine. Ultimately, he passed away and she was very sick. So from these case reports, now there are warnings to other individuals. So what about chiropractic? Well, there is actually a study, and in a week, we'll start posting some of these resources on our website. So this study actually reviewed the case reports for chiropractic, and it's a recent study. And using their study criteria, they ended up with 1,176 chiropractic case reports. Now, please note, these are only case reports that were indexed in PubMed. So, and some of the things that the case reports for chiropractic specifically focused on were rare or confusing presentations were presented, treatment of the patient, adverse events were something that were presented in the chiropractic literature, and then education. But here's the thing, that 1,176 seems like a lot, but when you think about it relative to other conditions, and this is from the article also, you see we're still very small in number. In fact, when they compared it to the pediatric cases, it's a 25-to-1 difference. So that's why learning and doing case reports on your patients is so important to kind of boost the literature and share the information about what we do as chiropractors on a daily basis. Now, also in this article, there were conditions that were most reported were musculoskeletal and connective tissue. But the second and third were injury, poisoning, and other consequences of external uses. Keep in mind in research, we always have to kind of put bumpers around things. So that's why there's some of those categories, and then diseases of the nervous system. But another really interesting thing that came out of the article is that when they talked about how often cases present to the chiropractic office relative to how many cases were actually present, there was a difference, right? So vertigo and loss of equilibrium is something that's seen monthly in the chiropractic offices. But over the time period, there were only 7 case reports in the chiropractic literature that talked about it. So this means that there's an opportunity for us to share information even about our day-to-day operations, things we take for granted that we have an impact on. And then on the flip side of that, hereditary multiple exostosis, rare. A chiropractor may only see 1 case a year, but yet there were 54 case reports. So again, it's kind of a call to action for you as chiropractors to start to share this information. Now, before I transition to the other presentations, I wanted to give you just a little bit of information about some definitions, because not all case-based research is the same. You're going to hear terms case report, case study, and these are often used interchangeably. So The degree is really, the difference is really about the detail. So think of a case report as, oh, a patient came in, that's kind of interesting. I think I'll write it up. So it's kind of that perspective. Think of a case report or case study as a clinician, maybe you see a lot of autism patients. So you think, okay, I want to add in an outcome measure like the Autism Treatment Evaluation Checklist or ATEC to start tracking this information. And then when you get a collection of autism patients, you can provide a more detailed perspective. So a case study is really just leveling up the information a little bit and providing more detail. The other two that you'll see in the literature is single subject research and N of 1 randomized control trials. Again, these are used often interchangeably, but there are subtle differences. Now, both of these are a systematic approach. Both of them use your patient as the control. Just some, like in the single subject, the patient is not getting any intervention. Possibly in the N of 1, then they may be getting a placebo or a sham chiropractic adjustment. So those are kind of the main differences. And also with your N of 1 randomized control, these are literally randomized control trials. So you have a randomization protocol. It may be one patient, it may be 5 or 6 individuals. And essentially what happens once you start it, you'll have, let's say A is your baseline. So there's no intervention there, right? B would be your intervention, whether it's chiropractic or a particular drug therapy. And then they might start with a baseline and then they transition into a therapeutic intervention. Then they're going to withdraw the therapeutic intervention or put them back in the sham or placebo and then bring it back. Because the thing with the N of 1 is they're going to repeat this over and over again until they can actually draw some conclusions. So that's just a very brief information about these other nuances. So that concludes kind of the history and value of case reports. This is one of my favorite cartoons, and I think it's really appropriate for case-based research because, your case-based research provides this little information, right, that kind of starts the conversation. Oh, well, then there's this, then a miracle occurs. Well, what that really means is we need additional research. Great, this is a wonderful starting point. So where can we go next from a research perspective? So thank you for that part. And now what we're going to do is we'll transition over to Dr. Sean Neff, who is with the West Virginia VA. He can share a little bit of information about his background, and then he'll be talking about an editor's perspective. So give me a moment to close off the slide share.
All right, well, I'll go ahead and get started. My name is Sean Neff. I'm the editor-in-chief of of the Journal of the International Academy of Neuromuscular Medicine. And I am a chiropractor, and I guess I would consider myself somewhat of a mid-career clinician researcher. I think doing research is quite a bit like kayaking, where you're a beginner until you've done one, and then you're kind of moderate. And then the more you know, the more you realize that you're not an expert, and you just stay moderate for a really long time. So, but I am going to give you an editor's perspective on case reports, case studies, and case series. So if you have any questions, feel free, but I do believe we're having a question and answer session at the end. So, like Dr. Sullivan pointed out, the first medical reports and articles were essentially case studies. It was all medical research essentially at one point was just, healers and doctors saying this is something that happened and other people need to know about it, right? So that's how medical research started. The more complex forms of experimental research, randomized controlled trials, and then the meta-analyses and analyses, those came along much later. So all research essentially started with this, reporting things that you observed or things that you saw happen. And that's remained because these case reports and case studies are, number one, a quick and easy way to share a novel anecdote. Number two, they're really interesting to read, and they're a low-hanging fruit for research. Now, they're absolutely vital to medical progress. There's nothing else that works as well to quickly bring attention to novel things. So, like Dr. Sullivan pointed out, when COVID was going on, you saw these case studies coming out saying, this is what we saw, this is what we did. The anosmia that's come with COVID-19, that was initially reported as a case report. The different therapies that have been tried were initially reported as case reports. The different symptoms, the inflammatory disorders, the child deaths, all these things are initially reported as case reports. And that's one of the biggest strengths of case reports and case studies. But it's not the end of their utility. And we're going to delve into that a little bit. But I think the main take home is that the strength of these is that they're quick, relatively easy, and interesting to read, especially from an editor standpoint. Obviously, as the editor of a journal, I want people to read my journal. So having things that are interesting to read is helpful. So they've done surveys, and they found that about 60% of chiropractors, well over half, and over a quarter of chiropractic students indicate that they want to do research. They have an interest in conducting and publishing research. But when they actually look at chiropractors who have published research, the number falls. 6% is the high end of what they've identified. The number ranges between 2 and 6%. So, what's creating this barrier to chiropractors conducting and publishing research? And I think it's multifactorial. One is that there's a learning curve to research, and not all of us have the resources. Not all of us practice in a hospital or an academic setting where we have the people to collaborate with, where we have the infrastructure, where we have the time, and really importantly, where we have institutional review boards, kind of the trappings and mechanism of doing human research. So that's one of the beautiful things about case reports, case studies, and case series is that because of the institutional review board definition of research is that you have an experimental design that you're using, these don't fall under the research classification and thereby don't require institutional review board oversight. So these are a really easy thing to get into if you're a chiropractor practicing in the field, because you don't have to have access to an IRB. You don't have to be in an academic setting. You don't have to be in a hospital, or some other facility that has an IRB on site. Now there are private IRBs that you can contract with, in order to review, or you can utilize your relationships, with Life University or with other facilities or with people that you partner with to do research that does require IRB approval. And I know that, other types of research are going to be covered in later sessions, so I'm not going to belabor that point. But as clinician researchers go through their career, a lot of them try to climb this steep level of evidence pyramid, right? And you kind of start at the bottom of the pyramid, and you can see, opinion of experts, that's a low level of research, or a low level of evidence, but it's also one that generally requires someone else to say that you're an expert in something before they want your opinion. In vitro bench level research and animal research, those are still things that are going to require institutional oversight. But then you get into that case reports and case series. And those, like I said, don't require this IRB oversight. They're just administratively less of a lift. So they're a great place to start your research career. And I think, they're not such a terrible undertaking. They're fun to write. It's normally about something that you've seen that you're interested in and want to share. And they help you get comfortable with the process of generating scientific writing and going through the peer review process, which we're going to talk about a little bit more. So I think one of the first things we can talk about is just laying the baseline for starting into this case-based scientific inquiry is that you want to always document with the assumption that you're going to write a case report later. Just start every patient encounter. The first time you see a patient, gathering all the information and writing everything down. And not only does this help you when it comes time to write a case report, but it just makes your documentation more robust and more usable. From my experience, I don't usually know the first visit that I'm writing a case report. Or I know, usually near the end of that course of treatment that something interesting has happened, or that new information comes to light that makes me decide that I want to write this case up. So just doing that work of documenting and getting in the habit of documenting all the available information helps you. I think you still end up going back wishing that there was some other information that you'd collected initially, but it definitely trims down that list of things that you wish you had written down or wish you had asked about. So maybe you're in that pre-contemplative state where you like the idea generally of doing some research. Is my slide lagging? Are you guys?
I think.
You guys?
No, we can see you.
Okay. So maybe you're in that pre-contemplative state where you're thinking, okay, well, I'm interested in contributing, to the knowledge, contributing to the scientific record, contributing to what we know about chiropractic treatment or what we know about maybe the effects of chiropractic treatment. So what makes a case interesting? And are you guys seeing my slides change?
Yes, yes.
Are you seeing the most interesting man in the world right now?
We are, yes.
Okay. Just to the screen that I'm seeing in the research lab is showing like 2 slides ago. Sorry. It was just freaking me out just a little bit. I was afraid that it was going to stop making sense in a minute. So
we're with you.
So when you start thinking about what makes a case worth submitting, is that it should be of use to someone. And what does usefulness mean at the end? So, and Dr. Sullivan covered a lot of these different things. Things that you've never seen before, novel experiences, new conditions. But then there's the other things, maybe it's special populations, like pregnant women or children or zombies, trying a new treatment or trying an old treatment, but for a new condition. One of the first case study I ever wrote was for manipulation of a sternocleidomastoid joint. And it was a posterior inferior subluxed clavicle, which is not normally the direction that they go. When they go posterior and inferior, normally those are treated acutely with surgery because of vascular compromise. This patient had had it for years. It was just chronically there. I was never taught a way to treat that in school. So, in concert with some colleagues, I adapted, a treatment that we use for costosternal manipulation and adapted that to this. And then as a result of that, the patient had a good outcome. So I wrote that case study up. Sometimes just reframing things, or looking at things that we thought we knew, or things that we suppose we know, but maybe don't have the evidence for. So I think every chiropractic student knows that aortic aneurysms are a contraindication to chiropractic adjustments, but are they really? We say that there's plausibility that they could be harmful, but there's also a growing number of case reports and case studies showing where people who've had aortic aneurysms that are stable were treated with manipulation and didn't have adverse events. So that starts to build that level of multiple anecdotes that would lead someone to maybe do a higher level of evidence study looking at that phenomenon to determine, is this something where we shouldn't be treating, or is this more of a relative contraindication that's going to change how we treat? The same with chronic cauda syndrome. That's another, contraindication that we've all been taught, but case studies and then case series and then further retrospective studies have shown that chronic cauda equinas are potentially treatable by chiropractic care, whereas acute ones are more of a neurosurgical emergency. So kind of looking at all these things and then understanding that case reports have grown, they've become more complex, and beyond just the direct clinical experience, or identifying novel clinical things, now we use them to alert about adverse reactions or the lack of adverse reactions, new, like I said, innovations, and they can be used to look at ethical dilemmas or educational settings, which Dr. Sullivan touched on as well. So there's just a broad number of things that you can talk about and start to look at with case studies, case reports, and case series. So it's not necessarily always, some really rare condition walked into my office and I want to write it up. Although those are great to see, there's also those places where you start to see the gaps, right? So we need to mine those gaps. Like Dr. Sullivan pointed out, we seem to have a gap looking at dizziness and vertigo. It's a relatively common thing that we see, but not a place where we have a lot of research. There's a huge research gap in thoracic manipulation and thoracic pain, oddly enough, which seems like it would be one of those water is wet case reports. But these are those gaps. So as you start to think more about research, start reading more research, read things about how to critically appraise research, and you'll find these gaps in our knowledge and these gaps in what we're reporting. And I think paying attention to the gaps in the evidence are one of the best ways to determine what's going to be useful as a case study. Now, an important thing to know is that not all journals accept case reports for publications, but many do. The journal that I'm the editor for does. Many other journals do. Generally, Spine doesn't. JMPT generally doesn't. Chiropractic Manual Therapies generally doesn't, but most of the other chiropractic journals do accept case reports and case studies. So when you're looking at this, I think it's a great idea when you start thinking about doing case reports and case studies is to have a journal in mind. Check out some of these different journals and check their instructions for authors page. It's going to be the most important page that you go to on that journal, besides when you go to see your article in print. Because this is going to give you, number one, different types of studies that they accept for publication and their general focus. The journal that I'm the editor-in-chief for, we focus generally in the realm of chiropractic orthopedics. So that's generally where the interest is going to be. Our readers aren't necessarily looking for, maybe more vitalistic case reports, but there are journals that do look for those. So looking at that, and it's going to give you the instructions for how they want your paper structured. And then the other thing you can do is look at other case reports that journal has accepted, because it's going to give you a really big clue to how that journal likes things laid out, the different headings that they like to use, the style and copy editing that they utilize, and pay special attention to how their references are done. It's always a pain to have to go back and redo your references, and I would urge everyone to use any of the available free apps and websites that help you manage your references. It's a way easier way to deal with this. So now you've been thinking about this, you've been taking copious notes on these patients, and you've now had a case that you believe is of interest or fills one of the gaps in our knowledge. And so you find this journal and you write up your manuscript, and then you submit it. And so this is generally how the submission process is going to work. You submit your manuscript, it goes to the journal, an editor is going to distribute that out to peer reviewers. Now, peer reviewers are they're other people who do research. So these are going to be other chiropractors. If you're at a chiropractic journal, these are going to be your peers who are volunteering to review your stuff. Peer reviewers don't get paid. And they're going to critically review your manuscript. And they're going to send you back their criticism. And I think that this is one of the most harrowing parts of doing research, is to create something and to send it out and then to receive criticism back on it. And the thing that I always tell early career researchers is the most important thing, I think, is to take this criticism in the spirit that it's given. And not that there aren't mean peer reviewers, and sometimes even whole journals that seem capricious in the review. But by and large, like I said, these are people volunteering their time to help improve your paper to make it a better product that's more useful. So when you keep that in mind, I think it's maybe a little bit less painful. Although it does still sting. I've been doing this a long time. I still occasionally get ones that maybe hurt a little bit more than they should. But I just keep in mind, and I've probably delivered ones that maybe stung a little more than they should. So, but it's in an effort to make the paper better. So receive this criticism and receive it, like I said, in the spirit of making your research better. Make the recommended changes and write down what you've changed. When you resubmit these back to the journal, they're going to want the new manuscript with the changes, and they're going to want a list of the recommendations that were made and how you addressed them. So keep that in mind. And as you send this back, you'll say, here's the recommendation they gave, we accepted and made that change. Or there might be one where you disagree and you're allowed to, and you can say, respectfully, we disagree with this, and these are the reasons why. You're allowed to do that. You can also say, we agree with this change, but unfortunately, we don't have that information. Sometimes that's one of the things where the peer reviewer will come back and say, well, you should really include this information. And then you say, that would have been great information to have. I wish that I had it, but I don't. So we also agree that that would be useful, but unfortunately, that wasn't available at the time. So make those changes, and then you resubmit. And it goes back to the peer reviewers and to the editor. And sometimes they say, excellent job, and then it gets published, and that's great. And then you get to celebrate. And sometimes they send back more criticism, and you go through that cycle again. So it seems daunting and it can seem tough, but it's certainly worthwhile. And at the end, if you persevere and do these steps, then you can demand that your children introduce you as a published clinical researcher, like I demand that my children do. So the do's: always, 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 always obtain the patient's consent to publish a case study. Journals have forms available. It's going to be on that instruction to the author's page. There'll be a link to it. Now, if you work in an academic or institutional setting like I do, your facility may have a form that you also have to use. And generally, editors are pretty flexible as long as it's a consent form that says all the things they needed to say. Sometimes they'll tell you that form's fine, we still need you to do ours because ours has something in it, and then you have to reach out to the patient. You're going to find out as we go forward that not having consent can, number one, be an ethical problem and a legal problem, but can also lead to embarrassing things further down. And I know, I think Dr. Russell's going to touch on that a little bit. Follow the instructions of the authors. They're there for a reason. It makes your life so much easier to not have to go back to change things that they've already told you how they wanted them. Give the relevant information. And this is something that I struggled with early, is I think I tried to give all of the information in order to, I didn't want to feel like I was not including something that someone may find important, but sometimes including information that's not necessarily relevant can make it just a little bit harder to read. But that's going to come through in the peer review and editing process. So you'll kind of find a way to right size that as you start to do these. And then do get help. I just spoke with the chiropractic residents in the VA a few weeks ago, and I told them to find their shrewdness, which shrewdness is the technical word for a group of apes. I said, find other human beings that you want to do research with. And I think it's great to find people who are better than you at research because they're helpful. And then it's great to find people who are relatively in the same spot you are as well, because then you can bounce the questions off of them that you think are too stupid to ask, your better peers. And then if they also don't know the answer, then maybe it's not that bad of a question anyways, then you can kind of run it up. I find that to be helpful to have, kind of your aspirational peer, your relatively equivalent peer. And then it's always nice, I think, to help the people who are coming along behind you. Now, things to not do. Don't use personally identifiable information. Obviously don't use the patient's name or address or identifiable photos of them, and certainly don't use photos without a release, and whatever is required of anonymization for your facility and the journal that you're dealing with. Don't draw conclusions. Case reports and case studies are anecdotes, and they're interesting and they're helpful and they inform the way that we practice and they inform our future research, but they're not generalizable. And even when you start to look at case series where you have several anecdotes, there's an old saying that the plural of anecdote is anecdotes. The plural of anecdote isn't data. So we can't make generalizations based on case reports. So generally, you're not going to have a conclusion section in a case report because you can't really draw conclusions from it. So that's just a general rule of thumb and a rookie mistake that you see as an editor when you're working with early career researchers. Another thing is don't submit to more than one journal. They don't like it. It's generally considered unethical, and it will get them to reject your paper. And the most important thing is not to give up. It's, like I said, it can be harrowing to create something that you've worked really hard on and have someone who's better at that than you tell you how bad you are at it. The first case report I ever wrote, I sent to one of my friends who was way better at research than I was before I sent it in for peer review. And he actually sent me back more pages of corrections than I had pages of text, which was not awesome feeling. But all of his edits made my paper better. And I actually sailed through my first peer review. They literally just had a couple changes and it got published, which was really exciting. And it also took me a little bit by surprise the second time I submitted a paper and it just got torn apart in peer review. So you're going to have criticism come. I think working through that process makes it better. Conflict clarifies, and the more eyes you have and the more people you have poking holes in your manuscript, the better your manuscript will be, and the more sturdy it will be to people trying to poke holes in it once it's published. All right, so here's my shameless plug. I'm not going to get too far into this, but I had told Dr. Sullivan, I don't want to be the arbiter of what journals are good. I certainly shouldn't be. So I won't really talk about other journals. I named a couple that I know to not take case reports, but my journal does have a program where we work with early career researchers. If you have a case report that you would like to write, you have an idea, you have something that you think fills a gap, but you just don't really know where to start, if you reach out to me, our editorial staff will pair you with an experienced writer to co-author with you to help you through your first one. And it helps to create those relationships. Obviously, coming to something like this is great. You're going to, number one, learn. So this whole series that Dr. Sullivan has planned is fantastic. So I'm going to shamelessly plug it too. This is, number one, a great way to learn some of the basics. Number two, it's a great way to network with other early and mid-career researchers to help build those networks that allow you to do research. So, go to ACC RAC, do this series. Anytime you're walking through a conference center and you see a poster session, stop, even if it's not in your specialty, stop and just, see what's going on. I think the more you surround yourself with research and researchers, the more relationships you build and the more collaboration you get and the easier all of this is. So, just to cap off, case studies are the low-hanging fruit of clinical research writing. There's lots of support available. There's lots of people who want to help you. Life's research department is fantastic. I collaborate with them. Stephanie and I met years and years and years ago when we were both young and shiny, really early career clinician researchers. And, just through years of meeting and talking, we've now collaborated on three different things, maybe. So, find your shrewdness. Find the people that you like, that you share interests with, and work with them, and just start doing the things, and you'll get there. Don't forget to pay attention to the instructions of the author. Like I said, it's the most important page on any journal's website. From an editor's perspective, it's the one where we spend the most time, besides actually churning out the journal.
Hey, I'm Dr. Brent Russell. I've worked with Life University Center for Chiropractic Research for quite a bit of time. And as Dr. Sullivan said, I have been chair of our institutional review board. And I've been a member for a long time. And those facts do play a role in this. They play a role in why I'm here to begin with. What's that statute all about? Well, research ethics committees, or institutional review boards, as they're often called, their guiding principle is that of beneficence. Beneficence. Thank you, Dr. Hosek. Dr. Ron Hosek is here to help me out with that. The basic principle that research should do no harm. Now, usually when we think of research not doing any harm, we're thinking of negative consequences, adverse events from drug studies and things like that. Since we're talking about case reports, we're really talking about how we share information and what information we share. So I'm briefly going to cover some things about privacy and confidentiality, patient consent and permission to publish, which Dr. Neff mentioned, a little bit about vulnerable populations, protected health information. Protected health information you already know about from HIPAA guidelines. A couple statements about cases versus research, the role of IRBs, who's an author is a bit of an issue, a couple of comments about outcome measures, and a little tidbit about predatory publishing. So first off, you basically already know this from HIPAA training, but privacy and confidentiality are words that seem interchangeable. Privacy is important in talking about case reports because it's the right of the individual patient to make decisions about how their personal information is shared. Confidentiality refers to your responsibility as a doctor about what you share and how, and not sharing certain information. Dr. Neff brought up the question of, is patient consent required for publication of case reports? Yes, it is, as he said. I do want to point out that historically, that's not been the case. The attitude of doctors, depending upon the culture and the era, a lot of times doctors have felt like, I have the right to publish this information. Doctors have been treated as gods, or with such reverence that nobody really questioned their opinions. And many case reports historically have been published without consulting the patient. That's not true anymore. You can't really do that, except in certain circumstances. If there's a serious communicable disease like Ebola or COVID or something like that, then oftentimes that information will be published without patient consent because the welfare of the public may be at risk. And sometimes the patient's dead and they don't really care anymore. Next of kin should be consulted when appropriate. Now, as chiropractors, we're not generally dealing with that sort of issue. So the question is, do you have to consult the patient? Yes, you have to have permission. Realize that doctors and patients have different motivations and concerns when it comes to case reports. Doctors have a desire to contribute to the knowledge of the profession. As Dr. Neff said, we need to put information out there and fill those gaps in research. Then again, any doctor who does that likes to see their name in print. You know, there is a desire for personal achievement to be able to say, yes, I've published a case report in in such and such a journal. Sometimes doctors don't want to ask the patients. They're afraid they'll say no. And they may revert to the old attitude of, well, I'm the doctor. I'm in a position here. I know what's best. But sometimes patients think it's cool to have their cases published, but they also may not feel real good about it if they have some kind of unique condition, and publishing it people might know who they are and know they're impressed. They might not feel real comfortable with that. So realize they do have a right to privacy. They do have some autonomy in the decision. They can make the decision, and they have a right to, provide consent, having been informed what's going to happen. So also, if you're asking consent of a patient, realize that as a doctor, you're kind of in a hierarchical position. You're in a position of authority. Patients might feel funny about saying no. They might feel like it's going to screw up their relationship with you. They may perceive that you're arm twisting them, even if you don't mean to. But I've also seen doctors arm twist the patient, go a little overboard in, quote, asking permission, unquote, because they have a desire to put this case out there. Realize that if you ask a patient for consent to publish their case, it will change the doctor-patient relationship. You're introducing a different element than somebody coming in, receiving care, and going away happy. You introducing another facet to the relationship will change the relationship, possibly negatively, not necessarily, but it could. I have some experience with this. I've published exactly 3 case reports on my own patients, and the first patient felt a little funny about it. The second patient was okay. The third patient, it was actually planned ahead of time. He knew all the way that it was going to be published. Dr. Neff also mentioned something about signing forms, and it is better if you know that you're going to publish a case and you can get in touch with the patient. It's always better to use the form that the journal supplies. I've got the Journal of Chiropractic Medicine up here because I have published one case in there and we use their form. Life University's clinic system has a single sentence that when patients come in for care, they sign a consent that just says, I understand my records could be used for educational research purposes, and at least something like that. Realize that, there are cases, realize that if you don't get permission, things could go south. I have an example up here. In the upper right-hand corner, you can see the logo for Retraction Watch. That's a blog that writes about research, misconduct, retractions, and anything else that comes up. They write about plagiarism and article retractions. So, they wrote about a group of doctors who treated a patient with a mysterious mass. This is a woman who for 11 years had gone to doctor after doctor after doctor trying to figure out what was going on. These guys figured out what the mass was. They removed it. They diagnosed it. They figured, man, we want to write this up. They couldn't get in touch with her. Phone calls, letters, emails. She didn't respond. Finally, they said, man, we really want to write this up. We're publishing it. And she saw the paper. They figured she never would. She saw the paper and she said, you retract this. Fortunately, I haven't seen this happen with any chiropractic case reports, but it could. Don't let it be you. Sometimes patients give consent, and then when they actually see it in print, it's like, oh, wow, no, I wish I hadn't given consent for that. They can change their mind. They can ask for it to be retracted. Patients who agree to participate in research can change their mind later, and you need to go along with it. These things don't happen very often, but they could. Okay, next topic. So in general, when I say you need to get patient consent, I'm thinking usual and customary patients in a chiropractic practice, back pain, asthma, whatever they come in for. By federal standards, there are certain categories of people that you need to pay a little extra attention to, how you get permission and what the circumstances are, require a little extra consideration. Children, people with mental disabilities, you're thinking that they may not really be in a position to give informed consent. Children presumably aren't mature enough to understand the ramifications of giving consent. Some people are in kind of a vulnerable position. Pregnant women who are not only thinking of their own lives and welfare, but that of another person. People with physical disabilities, economically disadvantaged, prisoners, they're kind of in an awkward position and may not, federally, are they really able to give a neutral, objective opinion about themselves? Realize those are special considerations should you think that you want to do a case report on anybody like this. Next topic, confidentiality. As Dr. Neff said, and as you know from HIPAA standards, don't publish any names or dates of birth or social security numbers. I probably don't need to tell you that. But when you get into case reports, sometimes it may be appropriate to share a photograph of a person or part of a person. You may need to write it. The reason why you're writing the case report may be from some unusual diagnosis or condition they have. It may be appropriate to talk about their age or what state they live in. Maybe there's some kind of regional consideration. You need to think twice about what you're writing and how and whether it will be identifiable. I reviewed a case report by a faculty member at Life University once that gave so much detail about a patient. It's like all her friends and family would have known exactly who she was, and maybe even patients in the practice who didn't know her. So we had to dial that back a little bit. So think about that. There's a question in research, and Dr. Neff touched upon this. Are case reports and case series research? Are they? Some people say no. I have seen, I was at a convention of IRB, Research Ethics Committee chairs once, where I asked a question about case reports, and several people had kind of whipped their heads around and said, no, case reports aren't research, adamantly. Well, they sort of are, they sort of aren't. Federally, research is defined as systematic investigation designed to develop or contribute to generalizable knowledge. Well, they're not systematic in the way of planned formal research. And because they're about specific single individuals, they may not be generalizable knowledge. They might not apply to anyone other than that one person. But they are published in peer-reviewed journals. They are peer-reviewed, they're screened, they are used by other people as references. So they're kind of research, and maybe if you remember Dr. Neff's triangle, they were kind of down at the bottom of that. So because they're sort of in that gray area of research or not research, institutional review boards, research ethics boards, research ethics committees kind of handle them differently. Life University's IRB, for example, doesn't really require the formal review process of more sophisticated research, but they do like our faculty members and anyone from the outside working in coordination with our faculty members or staff members to at least notify them that a case report's being done. They kind of want to keep track of who's doing what and stop somebody from doing something inappropriate. If you're in a position where you're working with Life University and you're unsure, you can contact the IRB contact them early rather than later and ask a few questions. I fielded a phone call from an outside doctor once who had spent 2 years developing a football helmet to minimize concussions. 2 years he'd been working on this project, never contacted anybody about approval. After the fact, wanted approval, and of course he couldn't get it. So it is better to ask permission beforehand rather than forgiveness later when it comes to IRBs. Our faculty members and anyone working with us who is planning research ahead of time has to take a research ethics course, protection of human participants in research through the CITI program, Collaborative Institutional Training Initiative. So it takes a few hours. It really tells you all these things I'm talking about. One other issue, who's listed as an author? Like, if you look at this little picture in the upper right-hand corner, I'm going to say this guy on the left side had a patient, wrote a case report, looked up all the background information, but he works in a clinic that this man in the middle and the woman on the right own. So they say, hey, we own the clinic. We're going to be authors on your study. In fact, we want to be the first and second authors because we own the clinic. Can they be authors? Well, are they contributing to the work? I mean, did they look up the background, look for other relevant peer-reviewed articles? Did they help write it? Did they help revise it and work up the final version? Are they going to be in on, the reviews and, the revisions and the whole publication process? If not, no, they're not authors. It doesn't matter if they publish, if they own the clinic or not. That sort of thing happens in academic settings sometimes. I got a quick comment about outcome measures, and here we're kind of also encroaching upon other presenters' territory today. Use valid and reliable examination procedures. Chiropractic's got a ton of evaluation procedures for patients. Some of them brand new, some of them great, insightful ideas, very innovative. Some of them a little crazy. Kind of have an idea of what you're dealing with. Are they valid? Do they do what they claim to do? Are they reliable, meaning consistent? You can use something new and novel. Just understand what it is you're dealing with, because if you're trying to put something out there that doesn't make any sense, that's not ethical. Note that some questionnaires and surveys may be great, but they may be licensed. This happens a lot in psychology, but sometimes psychological-based questionnaires that chiropractors would use, you might not be able to use that thing ethically without permission or paying the fees for it. Dr. Neff mentioned something about you want to publish. Where are you going to publish it? Do your homework on the journals. Hey, I kind of have an interest in predatory publishing. A predatory publisher, these are basically fake journals that are looking for people kind of desperate to get an article published. A lot of times they're looking for early career researchers or newly minted PhDs who are like really trying to get something on their resumes, and they have no peer review process. They'll publish anything as long as you pay the fees. Could be $120, could be $720. I got an email, I get these all the time. I got an email from Spine. Spine, man, that is a big name journal. Spine is contacting me, inviting me to submit an article to them. Well, dang, I want to publish in Spine for sure, except it's not Spine who got in touch with me. Spine would be great, but I got contacted by Jacobs Publishers Spine Journal. Jacobs Publishers will publish anything as long as you pay them the fee. And when you go through a journal like that, they're publishing a lot of crap, a lot of stuff that isn't true or is poorly done. And that's where the ethics kind of comes into this. Do your homework. I've got a list of all the current chiropractic journals here. Let's see, this long, wide green one here is Dr. Neff's journal. And I proud to say I've published one article in that journal. He mentioned that Journal of Manipulative Physiological Therapeutics and Journal of Chiropractic Manual Therapies usually don't publish case reports. A lot of these others do. Look around, ask questions, do your homework. And I think, wow, I'm through. I hope you guys got something out of that. Thank you very much, Dr. Sullivan.
Awesome. So we're going to wrap up, like Dr. Sullivan said, just by going through every single step of a case report or case study, step by step, to literally dissect the best things to include and then perhaps some things that we should really avoid. So basically, the first things first, I do want to introduce myself. I am Rebecca Deo, as they mentioned. I'm currently practicing in private practice in Grand Rapids, Michigan. I was very fortunate to be published twice as a student and twice more within the first couple years of practice. A couple of those were case reports. I did a narrative review of literature as well, and then recently just did another one with Dr. Sean Neff. We did a study regarding COVID and chiropractic. So I also went to Palmer College of Chiropractic, graduated from the main campus in Iowa, and I did the Martinsburg VA Medical Center clerkship with Dr. Sean Neff as well. And that picture actually is me with my newest little girl. She is 3 months old, and you can imagine how much fun putting together these slides while holding her was. All right, so brief overview. Like I said, we're going to start off with step by step, and with each step, I'm going to tap into the do's and don'ts, and then at the very end, we're going to transition into something a little bit different. While we were talking about what we wanted to include with these 4 presentations, it really came up that there are a few conversations that might be difficult to have, but are pretty important when you are in the process of writing a manuscript. So we're going to talk about those, why they're important, and just give some examples of how to go about doing them. All right, so first and foremost, let's talk about each step of the case report. So most of these are going to sound familiar to you guys. I'm still going to go through them though. This is based on just a general idea. However, we always recommend that you do check the requirements that are listed on the website of the journal that you're going to be working with. So to start off, it's going to be the title. Obviously, you're going to need a title. We're going to dive into that in just a little bit because there are some pretty important rules when it comes to title picking. After that, generally, there's going to be an abstract, which is going to be a summary pretty much of everything. And you have to remember too, the abstract is really important because when people are doing their research, they're not reading every single paper they come across. Most of the time, they're reading that abstract as fast as they can to determine if it's a paper that's going to help them or not. So the abstract is very small, but very important. The introduction, self-explanatory. You're going to introduce the reader to what it is that you're talking about. This is really important to help them truly understand before they read everything, kind of the background about some of the things you'll be discussing. Methods and results. So those two kind of go together. The methods is going to be a play-by-play of the clinical approach and protocol that you took. Results, again, self-explanatory. You're going to share what you found. And this is a section that surprisingly gets done incorrectly very often. So we're going to chat about that soon as well. The discussion section is where you actually talk about the results. And this is my favorite section, and you'll notice that I'll get really excited when we get to that slide. But the discussion is just, I like to call it like the meat of the case report or case study as well. Limitations are a part of the discussion generally. Limitations are very crucial, especially with this type of research, because there are a lot of limitations with case reports and case studies, as we all know. So it's important to identify those and explain why they could affect what you just did and what you just wrote about. The conclusion, we're going to wrap everything up in a brief paragraph just to inform the reader again of what this paper truly found. Acknowledgements. This is one that I feel like when I started writing research, I knew the least about. And Dr. Russell went into great detail here about who is an author and who is not an author. The acknowledgement section is where you include people who weren't necessarily an author, but perhaps helped with the manuscript. I know when I first heard about that, it made no sense to me. So we're going to dive into that as well. References are unfortunately the dreaded section, but they are very important. Obviously, as you research the information for your manuscript, you want to be tallying and keeping track of all of the papers and articles you find along the way. Those go in the references section. And lastly, we have tables and figures. Again, self-explanatory, but we're going to talk about the difference between the two. So first up, the title. Like I said, it's not as simple as it may sound. So the number one do for the title is to include the following 4 things. So number one, you always want to talk about the intervention that you used, whether it's spinal manipulative therapy, massage, dry needling, anything that you're using, you want that to be clear in the title. And next, you want to really outline the outcome that you witnessed. What was improved? What was the side effect? What was the eventual thing that came about with the study? The population of the subject is important to enter in as well. This could be something as simple as homeschooled students or males in their 40s, something just outlining who the population actually was. And then obviously the condition. We want to know what it is we were even looking at in the first place. So a big don't with the title, as mentioned previously in another presentation, you never want to imply causation because we have to remember that we are in fact doing a case report or case study. This is not a randomized controlled trial. So our title cannot say that we 100% found this. It can be generalizable because it cannot. We don't want to imply that also because we don't want people to read our title and think that it is an RCT. So we want to make sure our title makes it pretty clear that it is just a case study. Another don't is to get fancy with your titles. And that was a little difficult for me at first. I tend to be on, the end of the spectrum that likes bright colors and videos and movement and exciting things. But I realized very quickly in research that you have to be very literal. And thankfully, that's easy to achieve if you follow those 4 rules we just talked about in the do section. So avoid things that don't give the reader a true, clear focus about what your paper is going to be about. So because this can be confusing, I really wanted to provide a couple of examples and then explain why they might be good or bad. So title number 1, increase in shoulder range of motion among stay-at-home mothers. This one's kind of tricky because it actually sounds okay, but it's actually not good enough. We're not hitting all of those 4 criteria. We're not even saying how they got the increase in shoulder range of motion. We're not even saying what condition they really had. There's just a lot of pieces missing there. So sometimes titles can sound good, but really they're missing a lot of information. So that one's a big no. The one in the middle, title number 2, changes in isometric low back extension endurance times after an endurance training regimen in an office worker with low back pain. Although it's lengthy, this is more of the norm for what a title should look like. All 4 pieces are in there. It is clear, concise, to the point. This one is a big, big yes. The last one, spinal manipulative therapy improves marathon endurance in runners. Although that sounds great, again, it really leads us to believe that this was more than a case study or a report, and that it was actually generalizing that this will always improve endurance in runners. So this title is a huge no-no. On top of that, it doesn't even have all of the information that we need as well. So those are a couple examples. I really hope they help. So let's transition into the abstract. Like I said, very important, but usually pretty short. So the first do is to keep it that way, 100 to 250 words. A big tip that I usually do is I write it all out first, and I write more than what I want. I overwrite, as I would normally call it, and then I will remove afterward. It's always easier to overwrite and then remove pieces when you're going back in and editing than to underwrite and have to come up with more ideas. So that's my biggest advice there. Also, make sure you're following the specific recommendations from the journal you're submitting to. Generally, they're going to have an outline of exactly what they want in their abstract anyway. So just save yourself the hassle and head right to their website, pull up that form, and follow it accordingly. A next major do, is to use terminology that's going to be helpful in a general search. So obviously, whenever we're looking for research, we actually have to go into the search bar, type in a few words. You want to use keywords and popular terms that are actually going to get the reader to find your paper and for it to be useful for them. The biggest don't, already mentioned, is to just really, really find those rules from the journal itself. And when you find them, don't ignore them either, because as Dr. Neff talked about, you're going to get ripped apart during the editing process. The editing process is so crucial, so you always want to make sure you're avoiding even more fixes that they have to make at the end of reading your manuscript. So just follow the rules from the get-go. Here is a general layout of what an abstract tends to look like for most journals. So there's, a couple sentences about an introduction, a couple about the case report and methods, a couple about results, a few about discussion, and then finally there's normally a section for keywords. And this is just like anything else. It's like typing into Google. So you're going to find the keywords that you want to have your paper pop up for. Next up is the introduction. So the biggest thing here is to make sure you're using this to establish a true need for the paper and to explain its purpose. When they read the introduction, they should 100% understand why you wrote this in the first place. It's also where you identify and define key words that the reader is going to need to know in order to understand what you're even talking about. So this could be things like acronyms. I know in the one I just recently wrote last year, we talked a lot about different national organizations within chiropractic, like ICA, ACA, and we had to spell out what that means because there could be a chiropractor in another country reading it and they have no idea what those things mean. So acronyms, any kind of shortened terminology, anything that's just not general medical terminology should be identified and defined. And then the big don't for the introduction is to avoid diving too deep. You don't want to give everything away in the introduction. It should really just be a focus on background information, previous research, just giving your reader enough juice to familiarize themselves with what you're going to talk about. So next up is going to be methods, and technically the methods and the results section go hand in hand. They actually technically make up what's called the case report or the case presentation. So the method section is basically where you talk about what you did. So you want to describe in detail the absolute clinical protocol that you did. The biggest reason for this is because you want to increase reproducibility. The whole purpose of why we're writing a case study in the first place is because we want somebody to read it, take that information and look at your limitations and create the same study with maybe a tweak to make it even better. Because when we do that, that's how we lead to some of those very, very big randomized controlled trials, as previously mentioned. So when you're actually writing out your methods, you might be surprised by some of the things you have to include. So, for example, in the paper that we did last year, we surveyed chiropractors digitally after COVID, and we used a platform called Airtable. In the methods section, I literally had to say that I used the database called Airtable. I had to list where the headquarters were. I had to list how Airtable worked. I had to dissect every single question that I asked in the survey, letting them know if I used fill in the blank questions, yes or no questions, multiple choice questions. And it gets so, so detailed. But it's really important to do that because, again, if someone wants to reproduce that 5 years from now and survey chiropractors 5 years after COVID, they know exactly what I did down to the very last letter so they can reproduce that effectively. Another major do with this section is to use primary outcome measures. The reason for this is because you have to be able to quantify data for it to mean anything. You can have 50 patients and say that half of them have high blood pressure, but if you don't have an actual measurement of that, it's not really meaning much. And one, it's a lack of information, but more importantly, this can be misunderstood by readers. When someone unfortunately thinks of high blood pressure, sometimes the numbers are all over the place. Some people don't get worried until, the systolic number is 140. Some don't worry until it's 150. Some start to panic at 125. So that's just one example of many where when you have the numbers, you have an outcome measure, your data is just going to be better. It's going to be understood by all of your readers the way you want it to be understood. So in the world of chiropractic, a good example of this would be outcome assessments like back-borne myth or oswestry. Instead of just saying, oh, all of these patients had excruciating low back pain. We all know that pain is different for all of us. We can't just say something vague like that, but we can say 50% of the patients had this score on the outcome assessment. We could say 100% of the patients had a numerical pain rating score of 8 or higher out of 10. Now everyone's like, oh, okay, those are high levels of pain. So that's a huge, huge thing you want to include in your methods. A big thing you want to avoid is going out of order. In this section, you want to kind of start from the very beginning all the way to the end, focus on it being in chronological order. Again, this helps with reproducibility. The second part of that case report and case presentation is going to be the results section. For this section, it's really important to be concise, add information that's truly valuable. You're also going to be using a lot of tables and figures throughout this portion, but you want to make sure you're only putting information that truly adds value to your manuscript. This can be quite difficult because sometimes you get a surplus of information from what you're looking at. I know we were challenged with that with our study that we did last year. And you have to understand what's valuable enough to put in the writing and what can just simply be added into an accessory table down the road. In the results section, it's important to not have any personal opinions whatsoever. So when you read results section, I want you to think data, 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 numbers, 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 findings, findings, findings. Don't think about writing anything, oh, we found this because this. No personal opinions, no ideas, no concepts. And spoiler alert, you will have a time for this, but it's actually the discussion section. So we'll talk about that in a bit. This is crucial though, because there tends to be a lot of overlap. And this is one of the top things that editors are seeing when they're reviewing articles and papers. They're finding this as a major, major issue. So if you can just avoid this from the get-go, it's going to save you a lot of hassle. Another big don't is to avoid saying things that were possibly vague as a result, because again, you don't want that to be misinterpreted. So like we talked about, the example would be pain, but there's so many other things that could be vague. You don't want to use terminology that could imply that as well. So pull out thesaurus.com, pull out anything you need to help change terminology and make it more straight analytical. All right, so my favorite portion, the discussion and limitations. So first off, this is where you include opinions like I just mentioned. This is the only place in the entire manuscript where it's actually okay. Here is where you're going to talk about things that were in the introduction and things that were in the results, and then you basically talk to the reader as if they're right in front of you. And that's why it's my favorite part, because this is the one part of the study that is more human, I think. It's really like you're truly talking to them one-on-one. So what you can do is compare old ideas that you researched and put in your introduction, and then compare that to what you found in the results section and explain why. You know, previously we found this was the case with low back pain, but this study shows this. Maybe we found this because of XYZ. So it's kind of like you're laying a roadmap, and that's why it's my favorite part of the entire manuscript. Another major thing you should do is to provide and explain possible variables that could basically say why the outcome happened. So we all know that sometimes pain and medical conditions can be self-limiting. It's important to mention things like that in your paper, because like previously mentioned by other speakers today, this is an N of 1 in most cases. So just because one person responded a certain way doesn't mean that the next 100 people are. So variables are important to lay out. Another major do for this section is to basically provide ideas for future research. And you can do this with limitations very easily. You have to make sure you're explaining, one, what the limitation is, and two, why it's important. And that's the biggest don't I put here. Don't forget that part. Unfortunately, sometimes people will get to the limitation section and they'll say, future research is warranted, period. And then they move on. And that's a problem. You're leaving a lot up to interpretation. You're not providing any ideas for the reader. So a way to avoid that is to say something like, you know, in this study, we only evaluated someone of the male gender. A future study could be warranted to include female or non-binary or anyone else, to just see what else could possibly happen. And it's exciting to do this because you are encouraging other people to take your study and do more with it, which is, again, the whole purpose of what we're doing. And the conclusion. So the conclusion, honestly, is shorter than what people think. So a lot of the times there can be confusion between the discussion section and the conclusion section. The conclusion should be short, whereas your discussion can kind of be lengthy because you're talking about a multitude of topics. The conclusion here should only be about a paragraph, which is very, very important to remember. And in that paragraph, the number one thing you want to do, as listed here in the middle, is to reflect on the purpose of the paper. That ties back all the way to the beginning of your introduction, which is insanely important. They should understand, okay, in the conclusion, this is exactly why we did this, and the reader should really make sense of that. The biggest don't here is to avoid going through a summary of the entire case itself, because you have to remember they already read your methods, they already read the discussion, so keep this really, really concise. And acknowledgements. I mentioned before that this was actually the section that I knew the least about when I started writing research. So the biggest thing you want to do here is to include people who helped with your manuscript, but did not meet the true criteria for being an author. And if you're ever confused on what that means, look on the website of the journal that you're looking to publish in, and it will straight up tell you section by section what criteria have to be met. It was hard for me to understand this. And the reason why is because I had never seen an example of it. So to give you guys an example for it to make sense, last year with the study that we did for COVID, we actually had a DC who helped us analyze the data and provide us with database use for the numbers specifically. She didn't write anything. She didn't interpret anything. She didn't edit anything. Literally, all she did was help us crunch numbers and gave us the platform with which to do that. That was an acknowledgement. That was not an author. So what we did is we added her to that section. We listed her name, what she did, and what her affiliation was. So that's a really good example of how you can include somebody in there. The number one don't is obviously to include somebody who didn't contribute. If you have a colleague or friend, kind of like Dr. Russell mentioned, don't add them just because they need to be published. Don't add them because they have to meet a deadline or because they really want to see their name in writing like that. It's not a good thing to do. It's not right. References. So most of us are probably the most familiar with this section. We've been doing it since we were kids in school. The biggest do, especially in the profession that we're in, is to only use articles that are from peer-reviewed journals. There's a lot of good information out there in books and magazines, but they do not belong in research like this. So try to stick to peer-reviewed journals, do your scholarly research online. That is going to be very, very important. Number two, this is the most important to me, and I'll explain why. Use recent literature. This doesn't mean that literature from the 80s, 90s, early 2000s is no longer credible or no longer needed. It is, because we can learn from it, but you should not have a references section with the vast majority or even any being from those times. It doesn't make sense, especially from the world of musculoskeletal healthcare. Things have changed so much in the last 3 to 5 years alone. So I really encourage you to use only recent literature, preferably within the last 5 to 10 years. Obviously, much sooner would be even better. And thankfully, research is coming out like crazy these days. So there's plenty of things to work with. So I can't stress this enough. The biggest reason I'm stressing this like crazy is because our profession tends to forget this tiny detail. We have a subset of the population of chiropractors who really are grasping tightly to some studies from early on that honestly have no validity, like the Pero study. There's a few others out there that have become notorious. They're old. Some of them are actually false information. They don't belong in current new studies. So keep that in mind when you're researching. Be current. Your paper will be more valuable because of that. And lastly, another mention for the journal's specific instructions. Please, please, please. This is probably the most important section where you look at those rules, because in the references, each journal has their own rules on what specific format they want. It can even be as nitpicky as the font size, the font style, being numbered or lettered. I mean, the list goes on for little things that they could want. So I would recommend reading these rules and regulations before you even start researching for your paper, because you want to make sure you're adding them already the way that you need it. You don't want to spend hours after the fact doing this. So what Dr. Neff and I normally do, we get that layout, and then as we come across these papers, usually on PubMed and some of these other pages, you can just get the reference fully mapped out right there with the one click of the button. Then you can actually take that, copy it to your clipboard on your computer, phone, whatever you're working on, pull up a Word document and just copy and paste as you go, as you research. You can put notes in there. It's always good to do the work up front while everything's fresh in your brain. Definitely don't wait till the end. This can be so hectic and chaotic and very, very stressful. And lastly, tables and figures. So tables are going to be for clear and concise data that doesn't really fit in the manuscript itself. It's also going to be for things that don't need explanation with text. So things that you can just throw on a table and they just make sense with the numbers and words that are there. Figures are different. I want you to think of it as a laundry list. So a table would be something I could use for comparing, patients with different pain levels and their scores on NPRS, things like that. Figures could be, let's say I wanted to include the top 10 red flags for low back pain. I wouldn't put that in a table. That's more like a laundry list. So I would flat out say 1 red flag, 2 red flag, 3 red flag, all the way down. And that's more of a figure. Now, the next do for this is going to be consistent. You want congruency with all of your figures and tables. This can sometimes be in the rules section of the journal as well, but generally it comes down to using the same font, same colors, same font size, and just general styling. So we have 2 don'ts for this section. Number 1, never make a table for things that you can just literally write out in 1 or 2 sentences. You might as well just throw that in the paper instead of having a useless table. And number 2, never add sentences to explain the table, like I just said. The purpose is to eliminate text. And once I thought of it that way, that's when it made much more sense to me. And for future work, you guys, if you want to take a look at everything that we just talked about, I highly recommend you look at this paper itself. It's called How to Write a Case Report for Publication by Bart Green and Claire Johnson. This is where I got most of the information for this presentation today. And every single time I write a case report, doesn't matter, what type I'm doing, I always refer back to this paper because it's so good at outlining what we need to do. It's also from the chiropractic perspective, if you will, as both of them are DCs. And if you do have the link to my presentation, if you just click right on this picture, it will automatically send you to the PDF link online. So definitely check that out. And lastly, we're going to transition and talk about those 3 conversations, and then we'll wrap up here. So like I said, sometimes these conversations pop up. We don't know how to handle them. So I just wanted to touch on that very quickly. So the most important one is asking consent from a patient. As previously mentioned, it's sometimes a little daunting to do so. We don't know if they're going to say no. We don't know if it's going to be an uncomfortable situation for both parties, but it's really easy to do. So I wrote here on the right-hand side just a small example of how this can be done. It's as easy as saying, "Hey, Jim, it's been really great to see how well you've progressed with the new treatment that we've been doing for your condition. I'd love to write up a paper on it for publication that could potentially help other healthcare providers. Would you be open to that? I wouldn't use any of your personal information whatsoever." That's literally it, guys. And then they might say no, they might say yes. And to be honest, in my personal experience, they get really excited the majority of the time. Most of the work that we're doing does not involve anything that's embarrassing or controversial, unless it's extremely unique. So for the most part, people think it's great. They think they're becoming famous, even though you're not using any identifiable information. But don't be afraid to ask. It could be as simple as those words right there. The next conversation that tends to pop up is going to be getting permission from the company you work for. This was incredibly important for me because during my first associateship, I learned the hard way that my location was not really open to me writing case reports. And I can't remember all the details, but I don't believe I asked permission for the first one. And I learned after the fact that they didn't love it. And they're entitled to be that way. They own the practice, they kind of own the patients, and you don't want to step on anyone's toes. And so what I recommend is having that conversation up front. Really sit down and ask your boss, the owner, whomever it is, and just say flat out, I've had I recently had a really unique case and I would love to publish it as a case report in a peer-reviewed journal. Would you mind if I did this regarding Brooke's case? And normally, the boss or owner is probably going to say, "Oh yeah, I saw Brooke a couple weeks ago. Very interesting. By all means, go ahead." And this is wonderful, especially if you're going to be printing out any reports or printing out any of the SOAP notes. It's just good to know that everyone's on the same page. So I highly recommend you do that if you're an associate or work for a certain organization. And lastly, this can be kind of a touchy subject. It's how you decide the order of the authorship. So for example, if 4 people work on a manuscript, you kind of have to decide who's going to be 1, 2, 3, 4. In theory, it doesn't matter a whole lot, but sometimes the topic needs to come up. So it usually happens naturally. The order should technically go based on the amount of work that was performed. Sometimes the level of expertise tends to kind of float around there too. And sometimes it has to do with literary exposure. So let's say 3 researchers are going to work on a manuscript and then they add a 4th who's maybe never done this before. It's their first time. And so they might decide, oh, I want to make that newbie author number 2, just to kind of throw the name a little bit higher in there to give them some credibility. And that's okay to do. But what's most important is to make sure that person actually does the work. Always, always, always avoid partnerships that don't really appear to be fair, because there's usually an ulterior motive. And I've unfortunately seen this personally, where someone is an author and doesn't do more than 5% of the work. So early on, have conversations with people. The easiest way to avoid this is to delegate. Have somebody in charge of one thing, somebody in charge of another thing, based on what their strengths are. And I think that's the best way to go about it. I've been fortunate enough to work with really incredible people where I learned the right way to do this. So highly recommend that. So thank you guys so much. That is the end of my presentation. If you have any questions, comments, or if you'd like any more information, feel free to reach out to me via email. I am pretty easy to reach, even with a newborn. So I hope you guys learned something new today. Thanks so much.